Good afternoon, everyone, and welcome to today's webinar presentation, Catch-up of Routine and School-Based Immunizations for School-Aged Children and Adolescents. My name is Sarah Wilson. I'm a public health physician at PHO, and I have the great pleasure of moderating today's session. So before we begin, I'll just mention a few very short housekeeping items. So first is to enhance the presentation experience, the participant audio and video has been disabled. Please use the Q&A pod if you have a question during the session. We'll ensure there's ample time for a productive Q&A session at the end of the presentation, so we'll be using that Q&A pod to receive and answer those questions. And then finally, if at any point during the session you have any technical issues, please do email capacitybuilding@oahpp.ca. That's capacity building with one word, and they'll be able to help you in terms of any troubleshooting. So it's now my great pleasure to introduce the speakers for today's presentation. So we're very lucky to have presenters both from PHO as well as Niagara Region Public Health. So I'll introduce the first two PHO speakers, Dr. Nisha Thampi and Kelly Yu. So Dr. Nisha Thampi is a pediatric ID specialist and IPAC physician in the Division of Infectious Diseases at the Children's Hospital of Eastern Ontario, CHEO. In 2021, she joined PHO as an IPAC physician, providing support to COVID-19 immunization surveillance and IPAC sections of PHO's pandemic incident management response, including providing scientific secretariat support to the Ontario Immunization Advisory Committee. Dr. Thampi completed her medical training and residencies in pediatrics and infectious diseases at the University of Toronto and obtained a Master's of Science in Public Health from the London School of Hygiene and Tropical Medicine. Kelly Yu is a nurse consultant in immunization and vaccine preventable diseases at Public Health Ontario, supporting immunization scientific and technical support and knowledge products, as well as COVID-19 adverse event following immunization consultations. Her work encompasses a variety of activities related to public health surveillance, as well as management of VPDs and immunization guidance. Kelly is a graduate of the School of Nursing at the University of British Columbia and completed her Master of Public Health degree at the University of Waterloo. And now it's my pleasure to go on to introduce our guests and speakers from Niagara Region Public Health. Leslie Alderman is a manager with the Vaccine Preventable Diseases, or VPD, program area at Niagara Region Public Health. With over 17 years of public health experience, Leslie works with a multidisciplinary and public-facing team that's responsible for making an impact on the health of Niagara residents by reducing the incidence of vaccine-preventable diseases. She's responsible for planning, developing, implementing, and evaluating services to ensure access to vaccines, consultation, and public education. Leslie is a registered nurse and a graduate of the University of Toronto, having completed her Master's of Nursing degree in Health Systems, Leadership, and Administration. And then finally, last but certainly not least, we have Harjeet Chung, who is a supervisor from the VPD program area at Niagara Region Public Health. Harjeet provides program supervision, support, and direction to staff to ensure community-wide and site-specific public health clinic services are delivered with a focus on service excellence and innovation. She also works with the manager to continually strategize program improvements and streamline processes, policies, and practices. Harjeet obtained her Bachelor of Science in Nursing from McMaster University, and prior to joining the public health team, had experiences working in the community with primary care physicians to deliver direct patient care, including immunizations across the lifespan. So now it's my great pleasure to start the session. I'm going to hand it over to the first presenter, who is Kelly Yu. Kelly, over to you. Thank you.
Thank you for the introduction, Dr. Wilson. Moving on to the learning objectives for this presentation. Dr. Nisha Thampi will cover the first two learning objectives of this session, which are describe the impact of the COVID-19 pandemic on the delivery and coverage of routine immunizations, understand key principles, immunization principles related to routine immunization scheduling and catch-up. I will cover the third learning objective, identify and know where to access Ontario's publicly funded immunization schedules and extended eligibility guidance. Niagara Region will cover the final two objectives, apply key principles to common case studies that assess school-age clients for recommended immunizations based on immunization history, timing, and age. And finally, describe a training approach for new public health unit staff on the appropriate delivery of catch-up vaccines based on an interpretation of a client's immunization record. Dr. Nisha Thampi will now start her presentation on reviewing the impact of the COVID-19 pandemic on routine immunizations in Ontario.
Thank you, Kelly. There have been numerous factors during the pandemic that have impacted routine immunization programs. For one, there's been additional strain on the Canadian healthcare system, then restricted availability of in-person services, including public health clinics and primary care providers' offices, and limited resources, as we've heard about staff shortages, PPE shortages, and lack of physical infrastructure to maintain social distancing, especially indoors. And what we've also seen are school immunization programs being most negatively impacted, followed by preschool and adult programs. So this, here we have examples of vaccines administered in the school-aged cohort that may have been disrupted by the pandemic. These include school-based programs that routinely offer hepatitis B, HPV, and quadrivalent meningococcal vaccines in the grade 7 cohort, as well as community-based programs that deliver Tdap IPV and MMRV to younger children, and then Tdap in adolescents. Disruption of these programs has led to low school-based immunization coverage in the past 2 school years. When I say past school years, these data represent snapshots at the end of 2019-20 academic year, and then 2020 to 2021. As you can see, coverage estimates for the 2019, for those 2 school years are substantially lower than in previous years. And many grade 7 students, approximately 12 to 13-year-olds in the initial cohort initiated but did not complete their school-based immunization series. Then fewer initiated and completed in the 2020-2021 school year. As I mentioned, these are the 2 initial school years that were disrupted, and these data don't reflect a subsequent effort to catch up immunization activities that varied across public health units during the most recent academic year. So these findings highlight the importance of a catch-up immunization strategy for school-aged cohorts, and we'll spend the next few minutes discussing key principles. The individual's immunization status is a key consideration to determine the immunization schedule that's appropriate for their age and risk factors. And we can categorize their status as being unimmunized persons, having an inadequate record, or where they're unsure of their immunization status, or under-immunized. And the approach to assessing the immunization record for catch-up involves 3 key considerations before administering the catch-up vaccine. So determining their eligibility and recommended vaccines, determine their immunization status as we discussed previously, and then assess the validity of previous vaccines received. So I will spend the next few slides reviewing 7 key principles of catch-up immunizations. Number 1, assessing the immunization status at every opportunity. So at every health contact, reviewing individual vaccination history to determine whether any vaccine doses are missing or due. For example, newcomers to Canada may have had immunization records that may need to be translated. And depending on local practice, if the translation of the record is not possible, or if the individual cannot provide a history of immunizations received, if there's suspected falsification of records, or the vaccines received are not recognized or approved in Canada, they should be immunized according to the routine or applicable catch-up schedules. If there's no evidence or confirmation of vaccination history, we assume the person has not been vaccinated and then go on to use the age-appropriate dose and schedule. In general, the key principle number 2 is not to restart the immunization series. And as I was saying, in general, interruption of an immunization series does not require restarting the series, regardless of the interval between doses. However, there are a few exceptions, like cholera, and travel's diarrhea vaccine. So these are not part of the routine immunization series. Some series will require an additional dose or less doses if not administered as per the recommended schedule, depending on individuals' age and previous doses received. And then delays between doses do not result in a reduction in the final antibody concentrations for most multi-dose products. Okay, so having a longer interval is not problematic in terms of the immune response. However, maximum protection and robust immune response may not be attained until the series is complete. So really key to completing that series. Principle 3, observe the recommended intervals between doses in an immunization series. So minimum intervals. So in this context, so before we were talking about delay, the consequence of a delayed dose, but here we're talking about the minimum dosing interval. And that may be considered in certain circumstances. So when catching up an individual who is significantly delayed in starting or completing their immunization series and is at high risk of morbidity if exposed. And again, can't reiterate this enough, maximum protection is generally not attained until the complete vaccine series has been administered. And for this reason, catch-up schedules do take into consideration the minimum interval between doses so that optimal protection can be achieved within the shortest amount of time while still being effective. There may be exceptional circumstances, such as in the case of unplanned travel or in outbreak situations when multi-dose vaccine series need to be completed as quickly as possible, that accelerated immunization schedules can be used. So number 4, use simultaneous administration or multiple injections as a catch-up strategy. When someone's behind in their immunization schedule, simultaneous administration of a vaccine can be a useful catch-up strategy because it increases the probability that a person will be fully immunized, and it minimizes the number of healthcare visits needed to complete vaccination. And I can say in our pediatrics clinic, this has been a really important part of the discussion because we want to be able to get these kids up to an optimal level of protection as soon as possible. But of course, with kids and with multiple injections, there have been some important practice considerations. And I would say it's not just for kids, for adults as well, but my experience has been with kids. So, a few practice considerations: using separate anatomic injection sites, like different limbs. And if multiple injections in the same limb are required, then separate the injection sites by at least 1 inch. Vaccines that are known to cause the most injection site pain, like Prevnar 13, MMR, HPV, ideally should be administered after other vaccines. And use techniques to decrease injection site pain, including education and preparing the patient, the individual or their family about pain management, topical anesthetics prior to the vaccine injection, and then sitting up during the vaccine injection can be less painful. Number 5, observe the appropriate spacing of inactivated versus live vaccines. So we talked about how simultaneous administration can help with catching up, but there are important differences in the timing of administration between live and inactivated vaccines. So with inactivated vaccines, they can be given at the same time or at any time before or after other inactivated or live parenteral vaccines. But with live parenteral vaccines, however, if they are not given at the same visit, there should be a period of at least 28 days before the second live parenteral vaccine is given. Number 6, determine the interchangeability of products. So in general, the same manufacturer's product should be used for all doses in a vaccine series. However, monovalent Hep B vaccines may be used interchangeably, even though their antigen content is not the same, but sticking to the dosage and schedules that are recommended by the manufacturer for the vaccine recipient's age group. And finally, schedule the next immunization appointment before the individual leaves the room, or ensure a recall system is in place until the individual is up to date, and providing them with their up-to-date immunization record following each visit. I will turn it back to Kelly now to speak to publicly funded immunization schedules for Ontario.
Thank you. Thank you, Dr. Thampi. Many of you will already be familiar with the publicly funded immunization schedules for Ontario guidance document, which was recently updated and is available online. This document includes routine immunization schedules, age-dependent catch-up immunization schedules, high-risk immunization programs and schedules, eligibility criteria for all publicly funded vaccines, and minimum and recommended intervals for multi-dose vaccine series. This is a screenshot of the publicly funded schedule beginning at birth. You may notice some recent changes to this schedule. The Rototech 3-dose series was removed and the Rotarix 2-dose series was added. And so that's the top red ellipsis. And on the bottom, there is the addition of a dose in Tdap in every pregnancy. Here is the catch-up schedule for children who are unimmunized, under-immunized, or unsure of their immunization status, starting immunization between 1 to 6 years of age. And this is a catch-up schedule for children starting immunization between 7 to 17 years of age. You'll notice a simplified catch-up schedule for children in grades 7 to 12. This is a recent update and a result of the extension of hepatitis B eligibility to grade 12, as well as all students are now eligible for HPV until the end of grade 12. There is no longer the need to differentiate between male and female cohorts for HPV since the initial cohort of boys have completed grade 12. Vaccine eligibility has been extended for those who missed doses for school-based grade 7 vaccines. Impacted cohorts who may have missed receiving doses of hepatitis B or HPV-9 as part of the school-based immunization program remain eligible for missed doses until August 31st, 2023. Starting the 2022-23 school year, expanded eligibility of the school-based hepatitis B immunization program allows students who missed their vaccine in grade 7 to be vaccinated under the publicly funded program until the end of grade 12. And finally, I wanted to also take the opportunity to highlight the extended eligibility of age-dependent high-risk vaccine programs. The noted impacted cohorts eligible to receive herpes zoster, HPV-9, meningococcal B, and quadrivalent meningococcal vaccines remain eligible for their missed doses until December 23rd, 2023. These extended eligibility criteria have not yet been posted online, but will be available and shared shortly. Thank you. I'd like to acknowledge the contributions that others have made to support this portion of the webinar. And if you have any questions about this presentation, please contact the Immunization and Vaccine Preventable Diseases team at Public Health Ontario at ivpd@oahpp.ca. I will now pass it on to our Niagara Region colleagues, Harjeet Chung and Leslie Alderman, for their portion of the presentation.
Thank you, Kelly. Hi, everyone. My name is Harjeet Chung. I'm one of the public health nurses on the vaccine team at Niagara Region Public Health. I will be joined by Leslie Alderman shortly as well, our program manager. And I just wanted to say that Niagara Region is really excited to have this opportunity to present today on the topic of routine immunization catch-up. It's really quite timely considering the numerous catch-up initiatives that may be underway at this time. So using the key immunization principles discussed, we'll start with applying the publicly funded schedule and the extended eligibility to some common case scenarios that you may come across as it relates to immunization catch-up of school-aged children. The various schedules for hepatitis B series and dosages are based on current age. So as per the note under Table 6, the 2-dose hepatitis B schedule and vaccine formulation is licensed for use for children between 11 and 15 years of age. For children who have not received their second dose prior to their 16th birthday, a 3-dose series is required. So in this scenario, we would follow table number 7 to complete our 16-year-old client's second and third doses, which would be administered 5 months apart. And just to touch on the eligibility, the Hep B vaccine for this client is publicly funded right now as per the extended eligibility, because clients born in the year 2006 are one of the cohorts impacted by COVID-19, and they're eligible to complete their series beyond grade 8. And as mentioned earlier, beginning in the 2022-2023 school year this fall, students who missed one or both doses of hepatitis B vaccine in grade 7 will have until the end of grade 12 to complete their series, whereas previous program eligibility for Hep B vaccine ended in grade 8. And for the HPV vaccine, we know that clients are routinely publicly funded to receive it until the end of their grade 12 year. And since this client is starting the HPV series at 15 years of age or older, we would refer to table number 11 of the publicly funded schedule and administer a 3-dose series of the HPV-9 vaccine, which would be given at a schedule of 0, 2, and 6 months apart. It's important to highlight that if this healthy client had started the HPV-9 series between the ages of 9 to 14 and then presented today at 15 years or older to complete the series, we would still be able to complete it using the initial 2-dose schedule. The note under Table 10 on this slide differentiates this. Let's move on to our final case scenario. This one is relating to interrupted vaccine series in a 7-year-old who presents to your office in order to update their immunizations. They missed their 4 to 6-year-old vaccines, the Tdap IPV and MMRV, due to the COVID-19 pandemic. For example, Tdap IPV Hib or PDSL is a preparation containing higher concentrations of diphtheria toxoid, and this is designated with a capital D, and it's administered for primary immunization of infants and young children less than 7 years of age. Preparations that contain a lower concentration are designated as a lowercase d, and the same principle applies to the amount of acellular pertussis antigen and its preparations. So when we're navigating this scenario, we would refer to table number 24 of the publicly funded schedule to ensure we are using the most age-appropriate product. Table 24 reviews Tdap IPV, TD and IPV, and or TD schedules for those 7 years of age or older who have not completed their series. And based on the routine immunization schedule, we know our 7-year-old client had 3 doses of Tdap IPV Hib at age less than 7 years. Those would have been given at 2, 4, and 6 months of age routinely. So in following this table, we would offer 1 dose of Tdap IPV, ensuring it has been 6 to 12 months since their previous Tdap IPV Hib vaccine. And if this client was less than 7 years of age with an incomplete series, we would refer to table 4 of the publicly funded schedule to complete series, again, with the most age-appropriate product. And that completes review of our case scenarios. I'll hand it over to Leslie Alderman to present on strategies we use at Niagara Region Public Health to train new staff on grade 7 catch-up program delivery. Thank you so much for your time.
Thank you so much, Harjeet. The next few slides will present a few strategies we use at Niagara Region to train new staff on grade 7 catch-up program delivery. These are the same principles that we would use on a large scale for all vaccine training. To get started, at Niagara Region Public Health, we use many resources to cover the required training needs of new nursing staff. To provide foundational knowledge on all aspects of safe and effective immunization practices, we do ask everyone to complete the online educational program for immunization competencies provided by the Canadian Pediatric Association. An orientation plan and calendar is created to allow dedicated time for both teaching blocks and self-directed review. We provide a physical or virtual orientation booklet for staff to work through. This booklet includes various checklists and links to resources and documents. Some resources include medical directives, policies and procedures, guidance documents, fact sheets, and information on where, how, and when to access the publicly funded schedule, the CIG, any NACI statements, and product monographs. The nurses also receive a package of mock records to work through, which are later taken up as a larger group. The teaching blocks include an introduction and overview of the vaccine program, vaccine storage and handling, consent and release of personal health information, the importance of comprehensive health assessment, the principles related to record review, documentation requirements, and for the purposes of our summer catch-up clinics, we focused on grade 7 vaccines along with Tdap and Tdap IPV. I'll go over these in a bit more detail in the next few slides. As part of the introduction and overview, we review the importance of immunization, what to expect in the role, goals of the program and services delivered, and the external systems that support programming. For staff who are initially trained to support COVID-19 mass immunization clinics and are now supporting the summer catch-up clinics, we highlight any differences between these catch-up clinics and the COVID-19 clinics. This includes any changes to clinic setup and flow, obtaining consent, roles at clinic, processes, cold chain, and documentation systems. An overview to the cold chain program is provided. This includes review of the required standards of practice for vaccine storage and handling, the services delivered related to cold chain, such as annual vaccine fridge inspections, transport of vaccines, managing excursions, and mitigating vaccine wastage. Any related cold chain documentation, and review of internal policies and procedures related to cold chain management. The policies and procedures include the importance of maintaining temperatures for vaccine storage within a fridge or cooler, regularly reviewing and recording temperatures, troubleshooting any out-of-range temperatures, and promptly reporting any issues with maintaining cold chain. We also review how to use the various temperature monitoring equipment, such as the digital thermometers and data loggers, the practice of keeping vaccine inside the insulated bag or cool cube throughout the clinic, avoiding pre-drawing of vaccine where possible, and the importance of protecting certain vaccine products from light. Training on the specifics of consent and release of information include review of the College of Nurses standards, together with reviewing corporate policies on access to information and privacy protection, consent to treatment, and the processes related to providing exemptions within the legislative acts. As part of the health assessment training block, the nurses learn about pre-vaccination counseling, vaccine safety, including contraindications, precautions, and concerns, and the importance of completing a comprehensive health history. For example, this would include review of allergies, any adverse events following previous immunizations, current medications, receipt of previous blood products, underlying medical conditions, any considerations for special populations, and how the client is feeling the day they are presenting to clinic. For the record review and vaccine assessment component, we use pillars and filters to work through this process. The pillars are the foundational pieces to immunization and services, and they include, but are not limited to, applicable specific product monographs, the NACI guidance, chapters of the CIG, recommendations from the ministry, and expert consultation with our internal medical officers of health and the immunization experts at PHO. Filters to consider when determining required versus recommended vaccines and publicly funded versus fee-for-service vaccines includes the publicly funded schedules for Ontario any related legislation, internal documents such as public health unit specific exception documents, if applicable, medical directives, and the panorama forecaster and logic, which does not replace nursing clinical judgment. The teaching around the grade 7 vaccines, hepatitis B, HPV, and meningococcal vaccine, focuses on describing the nature of the disease. This includes etiology and transmission, comparing and contrasting vaccine ingredients and preparations, identifying scheduling intervals for 2-dose versus 3-dose series, reviewing common precautions and contraindications, and describing health teaching related to vaccination side effects. We tie all of this vaccine information together with a challenge activity testing knowledge. This is an interactive Jeopardy style game. Some clinic-specific training for our summer catch-up clinics this year also included review of Tdap and Tdap IPV. We provided orientation on identifying specific antigens using their abbreviations and determining if their antigen levels are high dose or low dose. We identify which antigens are available as a single antigen vaccine, such as IPV, and describe tetanus combination vaccines in detail, reviewing which tetanus-containing vaccine would be most age-appropriate for various scenarios, such as when a combined polio vaccine would be required based on immunization history. One of the final areas for staff orientation includes review of the various electronic documentation systems used in the clinic setting. We provide training on Panorama, our internal electronic medical record, and the MIMS application. And we ensure that all staff are familiar and are able to review and complete a paper consent form as applicable. So tying all of this together by using the resources available and the teaching blocks, we work through mock appointment bookings and review of immunization records and provide staff opportunity to shadow clinic shifts so that they can continue learning in the practice setting. The clinic setting provide experience includes review of IPAC procedures, clinic processes and flow, client assessment and vaccine eligibility criteria, preparing vaccine landmarking, administration practices, including utilizing the card system strategies to improve the vaccination experience, documentation, recovery processes, and ensuring each client receives a record of vaccine post-clinic. Once staff have completed a competency test and feel comfortable, they initially complete program delivery under observation by a mentor. For any questions staff have during or after orientation, we aim to have an assigned mentor who is an experienced VPD nurse. We also have designated education days throughout the year for ongoing learning and development opportunities. So we really do hope that you found this content helpful. We've used these principles and this orientation approach for several years in our program here at Niagara Region, and we have found successes with using these strategies. Thank you so much for your time today.
All right, well, now is my opportunity to thank our excellent presenters, and thanks to all of our participants who have been entering questions into the Q&A chat pod as the presentations have progressed. So many thanks for adding those, and really want to encourage all participants to continue posing questions into that Q&A pod, because we do have until 1 o'clock to answer your questions. So this is really the time to enter those in. So I'm going to start first with actually the very first question that was posed. And the first question was asking a question, and maybe I'll pose this to Kelly, because it was a question of clarification in relation to some of the content covered about extensions to eligibility. And the question was asking about when that information would be made available and if it would be available in the public domain. So Kelly, is it possible to comment on that?
Yes, thank you, Sarah. It is a Ministry of Health document. The Ministry of Health has shared those extended eligibility criteria with us, which were recently updated. And it is, and they will be posted online and shared through your usual communication channels. So just keep an eye on that guidance and extended eligibility criteria coming your way. Thank you.
Thanks very much, Kelly. Okay, and then the second question we received, actually received this from more than one participant, was a request for some additional clarification from Harjeet about the very first scenario that was presented. And I'm just wondering, maybe as we get started with this question, maybe we can request our events colleagues to move to this slide. So and thanks very much for putting it up. So the question was in relation to scenario one, where the 16-year-old student who's received one previous dose of hepatitis B returns for series completion. And the question is to really ask for Harjeet to walk us through why 2 additional doses of 0.5 ml are recommended as to 1 additional dose of a 1 ml hepatitis B product. So Harjeet, over to you, I know you did answer this in the presentation, but maybe because it is a common question, maybe you can just walk us through this content again. Thank you.
Certainly. Thank you, Sarah. So in this scenario, it's important to highlight that though our client, who is 16 years of age, started the approved 2-dose hepatitis B schedule using the vaccine formulation that's licensed for use for children between 11 and 15 years of age, they will need to transition to a 3-dose series if they present beyond 15 years of age, which they did. So there is a difference in our HPV-9 approved 2-dose series schedule and how we implemented and how we implement the approved 2-dose hepatitis B schedule. So I will highlight the difference quickly. For HPV-9 vaccine, as long as healthy clients start the 2-dose series between the ages of 9 to 14, even if they present beyond 14 years of age, they can still complete it with just that 1 additional dose, because the age eligibility criteria for that 2-dose schedule is not inclusive. Whereas hepatitis B, healthy clients must start and complete the approved 2-dose schedule for hepatitis B vaccine between the ages of 11 to 15 years. And if they don't, then they will need to transition to a 3-dose series, at which point we would follow table number 7. And the note under table number 6 here highlights that rationale as well. I hope that answered the question or added some clarity.
That's wonderful. Thank you. Thank you so much. And that is certainly a common question that does come up. So I'm going to move to another question in the Q&A pod, and it's a question I think in some of the principles that were described, there was an emphasis on the opportunity for co-administration as a strategy for bringing clients up to date. And so there's a question that asks, can a COVID-19 vaccine be co-administered with other publicly funded immunizations? And so I recognize that the answer to this might also depend on the age of the client. So just wondering, Nisha, I see you nodding. Maybe I can turn it over to you to start and welcome input from the other panelists as well in terms of the response to that particular question.
Sure, I was nodding because of the age reference, because as we may be aware, the new recommendation that came from NACI for the Moderna Spikevax vaccine for children 6 months to 5 years, the recommendation was that it would not be routinely given concurrently with other vaccines, live or non-live. And that was a strong recommendation from NACI, but that's not out of keeping with their previous recommendations for COVID-19, for new COVID-19 vaccines, or a newly authorized vaccine in each of the age groups. There was the recommendation to wait 14 days between the vaccine product, and really just to prevent erroneous attribution of an adverse event to one particular vaccine or the other. But I can say that the evidence is encouraging that concurrent administration of vaccines, particularly influenza vaccine, there's just in the last few days, I think in JAMA Network Open, there was a study that looked at Pfizer or Moderna products co-administered with influenza vaccine, and again the data were reassuring that that while there was a slight increase in adverse events, that it really was well tolerated across the two products in the adult population. But we don't have those kind of rigorous data evaluations to say the same in children, and certainly not for the 6-month to 5-year-old age group.
Thanks, Nisha. Thank you so much for that. Okay, so this is an interesting question that we'll move to next. It's from a public health unit colleague asking Niagara about, I'll just read it here, recognizing that many PHUs are implementing some of the great strategies that have already been suggested. They're interested in understanding what success or if you can describe what your experience has been to date in terms of engaging with primary care providers in terms of their involvement with catch-up activities, both for routine immunizations, but also asking the question about school-based immunization programs. So interested if you could comment on that practice aspect.
Sure, Sarah. That's a great question. And here in Niagara, we do have a primary care, advisory and liaison group. So we have some representatives from primary care across the region that sit on that group. So there's a lot of open dialogue and communication with this group, who does, speak for the primary care population. And so we do a lot of communication through them. We field a lot of questions. We do a lot of brainstorming with them. And then we do our messaging through our primary care engagement coordinators within the health unit as well. So there is a lot of dialogue back and forth with our primary care providers as well.
Thank you so much for that. Excellent. Okay, and now we have a question that relates to one of the scenarios that was presented. So the scenario is the 15-year-old in which the sort of optimal answer to this scenario was that there would be 4 recommended vaccines. And so the question is asking for some commentary on sort of what that looks like in practice in terms of the sites of administration. And there's a comment here saying that the participant notes that their understanding is that they're not able to give more than 1 ml per deltoid. So maybe if there could be a sort of response to sort of what the practice would look like for that scenario, but then maybe someone could also comment on this issue of, is there a maximum number of doses that can be given at a single visit? I'm just looking to see if there's anyone who's interested to take this question on.
I think I could probably answer this question, or I'll try to answer this question. I know that Dr. Thampi did mention it in her portion of the presentation about the recommendations outlined in the CIG. So you do try and use alternate limbs when able, and then when not, we do try to space by at least 1 inch to make sure that there's adequate muscle mass and space between the 2 vaccines that are provided in 1 muscle mass. I don't know, Dr. Thampi, if you have any other additional comments to add to that.
I think these are such individual based decisions, for me, like we don't have a minimum or maximum. Like we generally try to get 2 in arms per visit, but these are, but we also recognize that it really depends on the reliability of the family. I mean, again, thinking with my pediatrics hat, so forgive me, I'm not talking about adults here, but it's the same principle of their reliability of being able to come back in, their tolerability with vaccines. So if they have a fear of needles, having that conversation with them about what's better, having more visits with needles or getting them over and done with at this visit, more at one time versus more visits with that anxiety that comes with each visit for a vaccine. So, I mean, I think there's the practical perspective of what the absolute number that can be given, which is hard to define because it really is about also maintaining that therapeutic relationship with the healthcare provider or the public health clinic provider, so that they will continue to get their vaccines and not be done with it after this challenging session that they may have. But practically speaking, there's no limit.
Thanks so much to you both. So I think the next question actually follows up on a theme that Nisha, you've just introduced, which is around, some of the anxiety that clients can have around immunization. And maybe caregivers and parents as well. But so the question is around adolescents, and if any of the panelists could comment or provide their perspectives on strategies used to try to help with decreasing anxiety at the time or up to the time of immunization, especially for adolescents who may be recommended to receive multiple vaccinations at one clinic appointment or one school-based session. So interested in comments and suggestions about strategies to reduce anxiety at the time of immunization.
Here in Niagara region, we do use the CARD strategy. So comfort, ask, relax, and distract. So as part of our routine school immunization pre-teaching, we would go in and provide information to the students and any school staff, and also provide resources to parents to talk to their children about CARD and all of those different sections of CARD. So, when the child is showing up at clinic, we talk about, what positioning they want to be in, if they want to sit up or they want to lie down. We encourage them to ask questions. We always have distraction approaches to have in place. We encourage them to bring a phone or an electronic device. We also provide some distraction things to use at the clinic. And we want them to relax, and really we make them take ownership of that experience. And we have found by implementing CARD strategies, we still do have some higher anxiety in that age group, or nervousness, we could say, but we have implemented it now for several years, and we use these strategies in all of our clinics across the lifespan, and we have found them really, really helpful.
Thank you, Leslie. I think I'm familiar with the CARD system, but for individuals who are not familiar with it, do you mind maybe just at a very high level commenting on some of the main components? And we'll certainly look to see if there's an opportunity to share some resources and hyperlinks about it after the session.
Sure. So the CARD acronym does stand for comfort, ask, relax, and distract. So we provide suggestions to the client about what that could look like for them. We, make them a partner in their immunization experience. So really giving them, the opportunity to ask questions, to say what they want this to look like, to really feel like, the experience is a shared experience. So Niagara Region was a pilot organization that we did CARD in the school-based campaign for several schools a few years back, and we continue to use it in all of our clinic settings. We have resources posted on our website. We provide information to schools, and like I had said earlier, to parents and to the students themselves.
Thank you. That's fantastic. Thank you so much. And it's absolutely critical to the immunization experience. Okay, well, we're going to shift gears a little bit in terms of the sort of thematic sort of structure here. This is a very different question to adolescent vaccination. It's about rotavirus, and it's a question about whether the rotavirus vaccine is only publicly funded until 25 weeks of age. So I think, the question is about public funding, but maybe there's also a more general response that could be provided around the age in infancy in which we tend to recommend initiation of rotavirus schedules. Just wondering if any of the panelists would like to respond to that question. So I don't see anyone's particularly enthusiastic to answer this question. I'll just share my knowledge on this topic, that I think because of some of the risks related to at least the background incidence of intussusception in young children, that there is some NACI guidance around, sort of an optimal time period in early infancy at which there is sort of a recommendation for initiation in a time period after which when there is a recommendation not to provide it. So this is a good example of a vaccine program where we don't catch up children into toddlerhood or into the preschool age. This is really a vaccination program for infants. And we'll look to see if there is maybe some other material that we can reference as some hyperlinks or nasty statements to refer to that. Certainly not a question that we were expecting as part of our catch up on adolescent immunizations, but an excellent question. So I think we're almost at time here. We have only 1 minute left, so I'm going to maybe transition to my thanks to the wonderful presentations that we've received today. I'd really like to thank Dr. Nisha Thampi, Kelly Yu, Leslie Alderman, and Harjit Chung for presenting, and thank all of our participants as well, everyone who joined today's webinar and for the great discussion questions. And just a quick note that you can expect to receive a brief and anonymous survey following today's session. Really would encourage you to complete this if you have time. We do use it to improve our programming. And lastly, to access past presentations and view confirmed upcoming sessions, please visit the PHO website. You can head to the Education and Events section and click on Presentations. So thank you again for your participation today, and I hope everyone enjoys the rest of their afternoon. Thank you. Bye-bye.